Hello again, ladies and gentlemen. We will talk here about the adrenergic antagonists, and this covers a very quintessentially important class of drugs known as the beta blockers. You will run into this on a daily basis if you're dealing with adults. If you're working internal medicine, family practice, either inpatient or outpatient, you're going to run into patients every single day of the week who are on beta blockers all the time. There are so many patients on beta blockers. It's one of the most common medications, and we will go into this in detail here. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click the link below in the description of the video or on the I button on the upper right hand corner of your screen, and it should link you up. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. If you subscribe, you'll have access to some of my premium videos in which I go over case studies as well as how to formulate a differential diagnosis and treatment plan, things which should come in handy as you get ready to study for Step 3 if you're taking that, or just for clinical practice. Thank you very much in advance for your support. So we'll briefly talk about adrenergic transmission and the adrenergic receptors. I go over this in a little bit greater detail in the autonomic nervous system talk. We'll talk about then the alpha-adrenergic antagonists. There's a few different types of these medications that I want to go into. And then, of course, the all-important beta blockers, beta-adrenergic antagonists. On the USMLE, for the most part, when it comes to medications, you really only need to know how these classes of medications work. The individual details of the medications is not so important. So that's in particular when you're talking about things like the different ACE inhibitors, for instance. You don't need to know the difference between captopril and lisinopril. However, when we're talking about beta blockers, because this is such a heterogeneous group, you really do need to know the difference between the different beta blockers. It's one of the only classes of medications where you'll really need to know the difference. For the most part, we leave this to the pharmacists, but when it comes to beta blockers, you need to know the differences between the different beta blockers, and we will go into that. So this is how catecholamines are transported in the presynaptic neuron, ultimately transmitting a signal to the effector cell or a postsynaptic neuron. So you start out with tyrosine. Catecholamines are synthesized from tyrosine. There's a biochemical process which ultimately will synthesize these biogenic amines, namely dopamine, norepinephrine. And so here you see dopamine, but this can get further converted into norepinephrine. These precursors can get metabolized by an enzyme called MAO. However, when dopamine and norepinephrine ultimately get synthesized, most of it will go into these vesicles, these storage vesicles, and this is a magnesium ATP-mediated transport that causes them to go into these vesicles. When a signal comes down the neuron and action potential is elicited, this allows calcium to come into the cell through these N-type voltage-gated calcium channels. Calcium allows these vesicles to dock, spilling their contents into the synaptic space. And then once these catecholamines are in the synaptic space, they can transmit their signal on this postsynaptic receptor. There's the catecholamines can be metabolized when it's norepinephrine, metabolized by this enzyme called catechol O-methyltransferase. That basically does the same thing as MAO, it just does it in the synaptic space. You have a presynaptic receptor, which is important here, known as the alpha-2 receptor. This elicits a negative feedback, which inhibits the calcium channel through a G-protein mediated cascade, which will be very important when it comes to negative feedback. So that's why this alpha-2 is kind of the black sheep out of these adrenergic receptors. That's why when you stimulate alpha-2, it actually has the effect of lowering blood pressure, whereas when you stimulate the other receptors, if anything, it's going to raise blood pressure. So there's a few drugs that come into play here. The MAOIs, which is they're used in psychiatry, not so much as much as they used to be, but they are used in psychiatry, and that has the effect of increasing the amount of norepinephrine that's stored in these vesicles, because it reduces the amount that is metabolized. Reserpine is not used so much anymore. We'll go into this in a little bit greater detail towards the end of this talk. and then some of the norepinephrine releasing agents, which allow these vesicles to dock and spill their contents out into the synaptic space. And this includes things like amphetamine, ephedrine, Sudafed, phentermine, and tyramine, which is actually found in fermented foods. These are the receptors, and I go over this again in greater detail in the autonomic talk. However, what you want to know is that the alpha-1 receptor primarily works to constrict smooth muscle, particularly on the vessels. This has the effect of increasing the systolic blood pressure and the diastolic blood pressure. So this exists on the blood vessels. When these alpha-1 receptors are stimulated, it causes vasoconstriction. It also exists in the urogenital system, particularly on the urethra and on the vas deferens and ureters. So this is going to be important when we talk about some of the side effects of the alpha-1 blockers, as well as some of the purposes for which we give these alpha-1 blockers. Alpha-2 receptors, remember, are your presynaptic receptors, which allow negative feedback. Beta-1 receptors exist on the heart in particular, and then the beta-2 receptors are on smooth muscle, particularly on the bronchi. These are the adrenergic antagonists that we're going to talk about. We're going to talk about the alpha-1 or the alpha-adrenergic antagonists, non-selective alpha blockers, alpha-1 antagonists, and the alpha-2 antagonists, which really has no clinical purpose, but we will talk about it because it does come up from time to time, especially if you have patients that like to take herbal supplements. We'll talk about beta adrenergic antagonists. These are your beta blockers, very, very, very important class of medications. Which can be divided up into a few different subclasses: the non-selective beta blockers, the cardioselective beta blockers, and the mixed alpha beta blockers. Okay, so the non-selective alpha-adrenergic antagonist is exactly what it sounds like. These are antagonists that work on the alpha receptors, and they work on both alpha-1 and alpha-2 receptors. These are not given very common clinically. The one indication for these particular medications is pheochromocytoma. Remember, that's that tumor that sits in the adrenal gland and it spills out epinephrine. The two drugs that make up this class are phenoxybenzamine and phentolamine, and the difference is that one is reversible and the other is not. Phenoxybenzamine is irreversible, and it is irreversible because it covalently bonds to these alpha receptors, and so once it bonds to the alpha receptor, that alpha receptor is permanently deactivated. So phenoxybenzamine is irreversible. It works both on alpha-1 and alpha-2 receptors, and the main effect of these non-selective alpha-adrenergic antagonists is on the alpha-1 receptor, but you will see one effect that is alpha-2 mediated, which we'll go into in a little bit. So phenoxybenzamine, irreversible non-selective alpha blocker, where you see this come up is in the treatment of pheochromocytoma. Usually this is given before the pheochromocytoma is removed. So you'll give this to the patient first. Remember that when we treat pheochromocytoma, we first must give an alpha blocker, then we can give a beta blocker, and then we can go ahead and do surgery. You want to make sure that you treat pheochromocytoma before you surgically handle this, because manual manipulation of the pheochromocytoma can cause epinephrine to spill into the bloodstream, and ultimately that can cause a hypertensive emergency. So we give phenoxybenzamine and then a beta blocker to treat these patients first. But you need to remember, and I talk about this in the endocrine section in internal medicine, you go give an alpha blocker first, then a beta blocker, then you can do surgery. Phentolamine is like phenoxybenzamine, but it is reversible, and this can also be given in pheochromocytoma. I will also just add here, phenoxybenzamine may also be given as chronic treatment for pheochromocytoma if the patient's pheochromocytoma is inoperable or if the patient is a poor surgical candidate. The effects of these non-selective alpha-adrenergic antagonists include a vasodilation, which makes sense because remember that alpha-1 stimulation causes vasoconstriction. So if you block these receptors, it's going to cause vasodilation, and that's going to reduce blood pressure. Remember that blood pressure is simply your cardiac output times your total peripheral resistance. Because we're reducing total peripheral resistance by vasodilation, we're going to decrease the blood pressure. When the blood pressure goes down, you're going to have a reflex. Remember, those baroreceptors they respond to your blood pressure and they stimulate the heart to pump harder and faster or slower. And so if you have a decrease in your blood pressure, well, your only way of raising your blood pressure is to increase the cardiac output. And you'll do that by increasing the heart rate. Remember, cardiac output is heart rate times stroke volume. So you can do one or the other, or both. But what we in fact do is we raise the heart rate. And so that is a reflex tachycardia. So if you give an alpha-1 blocker, you're going to reduce the blood pressure and then elicit a reflex tachycardia, which is your body's way of homeostasis. Your body's trying to raise the blood pressure back to what it was. So you should expect a decrease in blood pressure and an increase in heart rate. There will be a mild increase in cardiac output. That's not mediated by the alpha-1 blockade, that's actually mediated by the alpha-2 blockade. What's happening here is that because there is an alpha-2 blocking effect, we have more norepinephrine that's going to be secreted because we're inhibiting the negative feedback. That extra norepinephrine that exists now in the synapse is going to be available to stimulate beta-1 receptors, and that's going to increase cardiac efficiency. So there will be a mild increase in cardiac output that we see with these non-selective alpha-adrenergic antagonists. Non-selective alpha-adrenergic antagonists also have the effect of reversing the effects of epinephrine. The adverse effects of non-selective alpha-adrenergic antagonists are similar to what we see with the alpha-1 blockers, which we'll talk about in the next slide. That includes, most importantly, orthostatic hypotension. Why would you get that? So what is orthostatic hypotension? Well, what that is, and you may have had this once or twice in your life if you've ever been dehydrated, you're laying down and then all of a sudden you stand up and you get dizzy. Well, why does that happen? Gravity. So you stand up and blood goes down. It goes down below your heart, and that reduces the amount of blood going to your brain. And what can happen then? You can faint. And that often happens with people with severe orthostatic hypotension. They get a syncope episode. So your body's way around that is when you have decreased blood pressure, those baroreceptors sense that, and one of the things that it can do is it can cause the vessels to constrict, and that is going to raise blood pressure because it increases peripheral resistance. The way that that's mediated, however, is by alpha-1 receptors. And so if those alpha-1 receptors are blocked, you won't be able to vasoconstrict, and so you won't be able to get this reflex vasoconstriction that you would want if you have a sudden drop in your blood pressure. And so this is what causes orthostatic hypotension. So orthostatic hypotension is a very, very, very important adverse effect of alpha blockade, namely alpha-1 blockade. You can get nasal congestion. Why? Because this is exactly the opposite of the alpha-1 agonists. Things like phenylephrine, which is what you take as a decongestant. So you're dilating those vessels in the sinuses, and that causes an edema, which can cause congestion, particularly in the nasal passages. Ejaculatory dysfunction, that is because for ejaculation you need a sort of peristalsis of the urethra, which allows the semen to leave the penis. And so if you don't have that, you can get retrograde ejaculation or just an absence of ejaculation. So you can get ejaculatory dysfunction, and then nausea, vomiting. Not exactly sure where that comes from. Possibly from a little bit of dizziness if you've got orthostatic hypotension, but I'm not exactly sure. These non-selective alpha-adrenergic antagonists are contraindicated in patients with decreased coronary perfusion. Why is that? Because you can get that reflex tachycardia, and so if the heart has to work faster and you already have a decreased coronary perfusion, that's going to increase the oxygen demand. And so if you have that decreased coronary perfusion, the oxygen requirements may exceed what you can provide to the heart, and so it may cause ischemia. Alpha-1 antagonists are most commonly used in the management of hypertension, as well as for the symptoms of benign prostatic hyperplasia, not hypertrophy. Any good pathologist will tell you that it's hyperplasia, not hypertrophy, but BPH. So there are several of these alpha-1 antagonists. Prazosin, terazosin, and doxazosin are used for hypertension. Prazosin has some off-label psychiatric uses. It may be given for anxiety. Very commonly, it is given off-label for the treatment of PTSD and PTSD-related nightmares. But this is namely a hypertension drug. It's not first line, but it is something that may be considered and is often given along with a beta blocker, but you have to be very careful about, they're very powerful when given together. It can also be given, and often is given, with a diuretic because these alpha-1 antagonists can increase sodium retention. Tamsulosin, L-fuzosin, and also doxazosin are used for BPH. And they essentially work by reducing the tone of the bladder neck. So, and then also of the prostatic urethra. So doxazosin actually has the longest duration of action, and it's the only alpha-1 antagonist that's not renally excreted. Doxazosin is excreted in the feces, so you may want to consider that in a patient that's renally compromised. And tamsulosin, this is also known as Flomax, given very frequently in older men, is highly selective for the alpha-1A receptors. You don't need to remember the subclasses of the alpha-1 receptors, but alpha-1A is particularly expressed in the urogenital system. So tamsulosin is very commonly given, not so much for hypertension, but primarily given for BPH. The adverse effects of alpha-1 antagonists is the infamous first dose effect. So what this is when you give an alpha-1 blocker for the first time, you can get a very exaggerated effect. And so what you might want to do to get around this is to cut that first dose in half or a quarter. Give it right before bed so that the patient doesn't have this orthostatic hypotension. If the patient's laying in bed, you don't have to worry about them getting up and then falling down. If you give it to them in the morning, well, then you may have a problem on hand. So cut the dose in half, give it to them at night. Once they have that first dose and their body responds to it, then the next dose you give them, you can give them the regular amount, give it to them during the day. They should be fine, but this is a first dose effect. Of course, you can get orthostatic hypotension for reasons I already talked about, nasal congestion, ejaculatory dysfunction, and these drugs should be avoided as monotherapy for hypertension, particularly if the patient already has congestive heart failure. You should give alpha-1 blockers in conjunction with a diuretic. Okay. So the alpha-2 antagonist is known as yohimbine, and this is the only one you're ever going to run into. It is not given in clinical practice. However, you can go to any herbal supplement store, go to a GNC vitamin shop, and you will be able to find yohimbine that you can buy for yourself without a prescription. So for that reason, you should know about this because patients may be taking this and you don't know because it's not on their chart. This is why it's always important to ask, are you taking anything over the counter? Are you taking herbal supplements, traditional medicine, etc.? Yohimbine is an alpha-2 antagonist. Remember that alpha-2 is that negative feedback. It works to lower blood pressure. It lowers the amount of norepinephrine in the synapse. So if you're taking an alpha-2 antagonist, you're actually going to have the effect of raising blood pressure. As I said, it's not employed clinically. This is a medication that is used in traditional medicine. It comes from the yohimbe tree, particularly from the bark. And this is an evergreen tree that's native to West and Central Africa, sort of Nigeria area. It doesn't have any conventional therapeutic use. It is used over the counter as a dietary supplement, and commonly it's used for purportedly for sexual enhancement and as an aphrodisiac. So you may run into a patient who uses this. You'll want to know if a patient has hypertension, especially if it's a younger person. Are you taking anything? Sometimes you get young men who think that this is a good idea to help me in bed. There's some people out there that think that this may be a medication that can, or a compound that can help with erectile dysfunction. And so this is something you'll want to always check into if you have a younger patient with high blood pressure. Are you taking anything like this? The adverse effects, as you can imagine, because it increases the amount of norepinephrine in the synapse, are things like anxiety, irritability, hypertension, and tachycardia. You will never give this clinically. Okay, so moving on to the all-important beta blockers. Beta blockers are one of the most commonly prescribed medications in the US, usually in the management of hypertension and for its cardioprotective benefits in patients who have just suffered a heart attack. And the prototype beta blocker is propranolol. It was discovered by this man, Dr. James Black, who was a Scottish pharmacologist. He won the Nobel Prize in 1988 for the discovery of propranolol, which of course is a very important medication in our armamentarium. He also discovered the medication known as cimetidine, which is used for reflux disease and acid. So propranolol is your prototype beta blocker. It's non-selective. It works both on beta-1 and beta-2 receptors, and it is indicated for a whole host of things, namely for hypertension, but it's also given for other disorders, things like angina. It slows the heart down, reduces oxygen demand. That's why it's really good after a heart attack, migraine, and hyperthyroidism. It's also given for other things. So you may see propranolol given for people with performance anxiety. Because it reduces the rate of the heart, it can it can blunt the sympathetic reflexes. So you have a patient who gets really anxious when they have to go up and give a speech. Giving them propranolol can really help with that anxiety that comes with that may affect their ability to deliver a speech. So you can see propranolol given for that purpose. This comes up in psychiatry. Migraine, why does it help with migraine? Well, because it reduces vasospasm. By reducing vasospasm, you can supposedly reduce migraine, but this is only given prophylactically, so it's not going to abort a migraine. It's given for prophylaxis of migraines. And then hyperthyroidism, propranolol, because it works on beta-1 receptors, it inhibits beta-1 receptors, it actually acts directly on the SA and AV node, depresses them. And so it's used for supraventricular arrhythmias. It doesn't have any effect, however, on ventricular arrhythmias, those arrhythmias that arise in the ventricle themselves, only those arrhythmias that arise above the ventricles. There are some other non-selective beta blockers. Those include pindolol, nadolol, and timolol. Timolol in particular is given topically. It's given in the treatment of chronic open-angle glaucoma as drops. And beta blockers, when given topically, have the effect of reducing aqueous humor production, and that will reduce intraocular pressure. The adverse effects of the non-selective beta blockers include, importantly, bronchoconstriction. Remember that we are blocking the beta-2 receptors in addition to the beta-1 receptors. And beta-2 receptors, when they are stimulated, they have the effect of bronchodilation. So if we block the beta-2 receptors, we will have the effect of bronchoconstriction. And for this reason, non-selective beta blockers are contraindicated in patients with asthma or COPD, and you absolutely need to know this for the test. And for clinical practice, you will never give non-selective beta blockers to patients with asthma or COPD. You can give the cardioselective beta blockers, which we'll talk about in the next slide. And I can easily see a USMLE question which a beta blocker is indicated, maybe in a patient who has just had a heart attack or a patient who needs medication for hypertension, and they'll give you a list of beta blockers. One of them will be a cardioselective beta blocker, and that will be the correct answer. You can get hypoglycemia from beta blockers. Why do you get hypoglycemia from beta blockers? Because beta receptors, when stimulated, they stimulate gluconeogenesis and the release of glucagon, both of which raise your blood glucose level. So if you block that, it's going to be harder to raise your blood glucose level, and this is why we have to use these with caution in patients who are diabetic and taking insulin or oral hypoglycemics. This can cause exercise intolerance. Why? Because they inhibit the beta-1 receptors, and that slows down the heart. Beta blockers slow down the heart. That's why they're so useful for angina. It reduces oxygen demand. Well, if you go outside and play tennis and your heart rate needs to go up in order to provide oxygen to your muscle, and your heart rate is suppressed, then it's going to be hard to exercise because your heart rate can't elevate to the level it needs to. So it's going to make it harder to exercise. Beta blockers decrease GFR because you get a reflex vasoconstriction. So what's happening here is that your heart rate is going to go down. That lowers your blood pressure, and you're going to get a reduction or an increase in your total peripheral resistance. It also blocks, well, okay, I'm not going to go into that in more detail. So just suffice it to say that the reduction in your systolic blood pressure, the slowing of the heart, it reduces blood pressure, and you get an increase in your total peripheral resistance as a reflex from that, similar to how you get a reflex bradycardia with your alpha-1 blockers. And so because you have an increase in your total peripheral resistance, that includes the blood flow to the kidneys, and so you can get a decrease in your GFR. You can get arrhythmia from this, angina, and hypertension, not when you give the beta blockers, but if you were to withdraw them very quickly. What happens is if you give beta blockers long term, it increases the amount of beta 1 receptors in the heart, and so if you suddenly withdraw the beta blocker, you'll have the same amount of epinephrine, norepinephrine, but now you're going to have more receptors, and so the heart is going to be very sensitive to those catecholamines, and so you can get the opposite effect if you were to withdraw from beta blockers. So arrhythmia, angina, and hypertension, the exact opposite things of what we see when we give beta blockers. The cardioselective beta blockers preferentially target the beta 1 receptor, and this minimizes some of the adverse effects of the non-selective beta blockers, namely bronchoconstriction. The ones you need to remember are metoprolol. That's the one I would strongly suggest you remember because it's used most commonly. Acebutolol, atenolol, and esmolol. These are all cardioselective. Esmolol stands out in that it's got a very, very, very short half-life. We're talking like 5 to 10 minutes. And it's only used IV, and that would be during surgery. Esmolol is usually given, is only given in surgery, and when it's given, it's for intraoperative hypertension. These beta blockers can be used in patients with asthma or COPD, but you need to be very careful. They do have some beta 2 activity. However, in low doses, they're generally pretty safe for these patients. I will just point out, this is sort of 95th to 99th percentile stuff, but pindolol and acebutolol are actually partial agonists of the beta receptors. They have what's called intrinsic sympathomimetic activity, ISA. And because of that, they have less effect on glucose metabolism and heart rate, but they still have the effect of lowering blood pressure. So this is good for patients with hypertension who already have a mild bradycardia because they don't lower the heart rate as much as the other medications. So pindolol and acebutolol. They also have much less effect on glucose metabolism, and so this could be ideal in patients who are diabetic. Then there are the mixed alpha-beta blockers. These are also known as the vasodilating beta blockers. And the reason that these are useful is that they, in addition to blocking beta 1 and beta 2 receptors, they also block alpha 1 receptors. And so remember, if you block alpha 1 receptors, you cause a vasodilation. And this is really good because remember what happens when you block beta 1 and beta 2. When you block beta 1 and beta 2, you get a reflex vasoconstriction, and that can be really bad. What kind of patients would that be really bad in? Patients with renal failure. We don't want to constrict those arterioles if they already have poor perfusion to their kidneys and a low GFR. So if we can do anything to reverse that vasoconstriction, cause a vasodilation or relative vasodilation, then we want to do that. And labetalol and carvedilol are very good for that purpose. So the indications and adverse effects are very similar to the other beta blockers, with the exception that we don't get the vasoconstrictive reflex that's seen with the other beta blockers. There is a reflex, but it's basically being blocked by the blockade of the alpha-1 receptor, which allows a vasodilation. And so because of that, it has minimal effects on the glomerular filtration rate. So as I said, this is ideal for patients in whom vasoconstriction is undesirable, such as renally compromised patients, older patients, and then black patients, African Americans. They tend to have more issues with their kidneys when they have hypertension. Now, in most cases, and this is just a side, beta blockers are not really good for black patients. They don't respond to them as well, and you probably hear a lot ACE inhibitors, diuretics, beta blockers are what we should go to first. However, my experience has been working with nephrology has been that calcium channel blockers like amlodipine, Norvasc, are probably better first-line agents, especially given with diuretics for black patients when you approach them with hypertension. So that's just an aside there. So this is ideal for patients in whom vasoconstriction is undesirable. Labetalol, in particular, is commonly used as an alternative to methyl-dopa in the management of pregnancy-induced hypertension, so you may see that come up. Labetalol is really nice. It's got a rapid onset, so you can use this IV in hypertensive crises. You give 20 to 80 milligrams as a bolus, and it works pretty quickly. Some odds and ends. There are a couple drugs that we kind of talked about, going back to that transmission of catecholamines. Reserpine is a drug that isn't used so much anymore. It was used widely for hypertension. What this does is it blocks that magnesium ATP-dependent transport of biogenic amines into the storage vesicles, and so that's going to cause more catecholamines to exist in the cytosol of that presynaptic neuron. Consequently, the more that exists in the cytosol, the more is available for MAO to metabolize it, and so it's going to deplete the presynaptic stores of catecholamines. As I said, it was used for hypertension, but it's very rarely used now. You will see it possibly, I've never seen it, but depending on where you practice, you may see some psychiatric applications of reserpine. It is occasionally used in the treatment of tardive dyskinesia, but for the purpose of hypertension, it is no longer used, and definitely no longer used in the U.S. Guanthidine is, as you can tell, I can barely pronounce it because it is not used. It displaces norepinephrine from the vesicles. It was used for hypertension, but it is no longer used today. And the reason is that it causes a very strong postural hypotension. It impairs ejaculation and causes a really nasty diarrhea as well. So you're not going to see that medication. But these may come up on USMLE Step 1. If they do come up on Step 1, you'll want to know the mechanism. So reserpine blocks the transport of catecholamines into the vesicles, and guanthidine blocks takes norepinephrine, basically takes it out of the vesicles. So to recap, phenoxybenzamine and phentolamine are non-selective alpha blockers which reduce blood pressure. They're used in the initial management of pheochromocytoma. That's where you're going to see those pop up. Alpha-1 blockers include prazosin, which is used for hypertension, and tamsulosin, or Flomax, which is used for BPH. Major adverse effect is orthostatic hypotension, especially pronounced with the first dosage. So you'll want to cut that dosage in a third or a quarter, give it at night before the patient goes to bed, and then the next day you can start it as usual. Propranolol is a non-selective beta blocker, and it's used for hypertension, migraine prophylaxis, supraventricular arrhythmias, angina, post-MI, and thyroid storm. Big list of things that propranolol is used for. The contraindication, because it's non-selective and it blocks beta-2 receptors, is asthma and COPD. You will never give that to these patients. You'll never give a non-selective beta blocker to a patient with asthma or COPD. The adverse effects include hypoglycemia because it blocks gluconeogenesis and glycogenolysis, bradycardia because it blocks beta-1 receptors, and exercise intolerance for the same reason. Beta blockers are cardioprotective. All of them are cardioprotective because they reduce the heart rate and hence reduce oxygen demand. Beta blockers, when applied topically, particularly here we're talking about timolol, reduce the production of aqueous humor, and therefore they have use in the treatment of chronic open-angle glaucoma, but you won't use this for glaucoma emergencies. In that case, you're going to want to use the muscarinic drugs. Metoprolol is a cardioselective beta blocker that may be used with caution in COPDers, asthmatics, and in diabetics in whom a beta blocker is otherwise indicated. So you can use those cardioselective beta blockers. You'll still want to use them with caution because they do have some beta 2 activity, and that's going to increase as the dosage increases. And that's all I have for you here. If you have any questions, please write me a note below. Otherwise, I will see you next time.